Hi, everybody. Welcome to this week's Free Friday webinar. This week, we are joined by Jill Harkavy-Friedman, who is the Vice President, well, goodness, I can't talk this morning, the Vice President of Research for the American Foundation on Suicide Prevention. And she's going to talk to you today about suicide and what EAPs need to know. We are open to taking some questions as we go along, but if we get to the point that we have some material that we still need to cover, then we're just going to kind of push through and we'll finish up questions at the end. Jill, thank you so much for joining us. Take it away.
Great. Thank you so much for having me. And I just want to start by saying thank you to everyone for the important work that you do. I'm going to share my slides if all goes well. And there we go. Okay. And again, thank you for having me. And we're going to talk about suicide prevention for clinicians. And this is the plan for today is to start off with the scope of the problem of suicide. And the numbers are hot off the press, which we'll talk about that. I'm going to share a model for understanding suicide with the hope that it will give you a framework with which to, when you're speaking with someone, to learn about risk and understand how suicide works. Then we're going to talk about risk factors and warning signs, some about asking a person about suicidal ideation and behavior, and approaches to screening and assessment. So everybody is here with some level of experience, but I don't know the level that everyone has. So if these are things that you already know, I hope you appreciate the reinforcement. And for those people who this is new, I hope that you learned something. So again, as Julie said, I welcome questions as long as we can keep things moving, and she'll read them out loud and I'll be able to answer them, hopefully. I want to start off with how we talk about suicide. And this is funny because just yesterday I got an email from someone saying committed suicide, which we don't say because it's as if let's say you lost a loved one to suicide, it's as if your person committed a crime. And so we think of it more as a health condition. And so we talk about somebody that died by suicide, like died of a heart attack or died from diabetes. You might also say they ended their life or they killed themselves. But the most respectful way is to say died by suicide. We also don't rate suicide attempts. We don't say that they're either failed or successful, because think about it. Failed would mean the person lived, and successful would mean that the person died. So we just say a suicide attempt or death by suicide. And if you are used to the old language, totally understand, hopefully you'll catch yourself and try on this new way to talk about suicide. So how many people have been died by a suicide or have been affected by
Hi,
suicide?
Jill. I don't think the slides are changing.
Oh, really?
Yeah, they're not. We're still seeing the cover slide.
Oh,
Thank
really?
you.
Well, let me stop and try again. You didn't see this slide? I guess not. Okay, let me.
We are on the title slide.
Oh, let's see if we can change that. I'm not really sure. I'm unsharing and thank you so much for telling me. That would be a share. Let's try again. Window. Yeah. I don't know if there's something special I'm supposed to do here. Now you see the plan side?
Yes.
Let me put it on full slide. And I've changed it. Do you see a new slide?
No, we're still on plan.
Okay, let me see what I can do here. I apologize. I'm not sure what's happening here, but let's try it one more time. Slideshow. Are you back? What are you seeing now?
We are back at the title slide.
Okay, and now?
Still the title slide.
Change your view. You have to select another screen, the one that has the slideshow.
I only have one screen.
Ah, okay.
So it's not changing, is what you're telling me. This is very strange. I'm not really sure what to do with this because I am seeing them change. You're still seeing the plan slide?
We see you now.
Oh, that's interesting. Okay. I really apologize for this. I'm not sure what's happening.
It's quite all right. Sometimes WebEx has a bad day. We've learned
Yeah,
that.
what do you want to share? Optimize forever. Okay. Let's try it again. Okay, I am going to share, but I'm not confident that anything has changed.
Okay, we are seeing the plan slide.
Okay. I'm not on the plan. Now I'm on the plan slide. How about now?
Still seeing the plan slide.
Very strange. Okay, let me see if I can do this a different way.
And you're
Next.
hitting,
How about now?
it's showing the full, what happens when you click on slideshow?
I'm on slideshow.
You are. And then if you hit
Oh,
enter,
okay, wait. You just advanced to how many people have been affected?
Okay, you see that? But it's not, doesn't seem to be coming up when I'm on actual slideshow. Okay, do you see it now?
are
Do
you
you see it?
hitting like on the menu bar between animation and slideshow, there's an thing with an angle that looks like it makes it full screen. If you click on
No, I
that,
have it on full screen. I see the full screen. I mean,
okay.
I do this all the time, so I appreciate the,
Oh, okay. All right.
but presented by a full screen, keep slides update. Nope. So you see it now, just not on full screen.
Right. We're on
Okay.
the how many people have been affected slide.
Right. Do you see a full screen now?
No.
Okay, so if you don't mind, I'm just going to use it with the slides on the side so that we can proceed. And you'll
No,
see
that's
my next slide. Okay, you'll just see my
absolutely-
next slide. Okay.
that is
Okay.
absolutely perfect for any of you who need the slides bigger for reading or whatnot. There are numbers at the top of your screen. There's 100% with a plus and a minus. You can manually adjust it if you need to, make it larger or smaller or
Great.
whatever. But that
And I
perfect
will be
for you,
sending
Jill.
I will be sending a PDF of the slides as well. So let's proceed. Okay. So the question is, how many people have been affected by suicide? And like I mentioned, the numbers are literally out this past couple of weeks that 49,316 people died by suicide. That's actually a little less than 200 people than the year before. And the rate has been pretty stable at 14.1 people per 100,000. Now, obviously, those rates change depending on age, ethnicity, location, but this is the average. And the group that had the highest rate of suicide, which is typically the case, were the older folks who were over 20 per 100,000, starting at age 64. So those rates haven't changed. We haven't gotten to take a closer look yet because they are so new. It's also estimated that about 135 people are affected when somebody dies by suicide. And so you might be talking with someone who recently lost someone to suicide, and that's an important question to ask because more than 50% of people have been exposed to a suicide loss of someone close to them. It's actually closer to 60%. It's also important that to know that you might be the first line person because only 1/3 of people who die by suicide were known to be in treatment at the time of their death. So sometimes I think you are the frontline group that somebody might call. Also know that even if people are in treatment, they tend to be undertreated. If they're not taking medication, they tend to be under-medicated. If they're seeing a therapist, they tend to not attend every session. So when we think about suicide, we think about a number of biological, psychosocial factors, and I like to call them contributors, that contribute to suicide risk. Any one of them alone does not lead to suicide because there's no one factor or contributor that will lead to suicide. It's always a combination of this dynamic. Let me see if I can do this now, because I need to do my, this is animated, but if we can't do it, we can't. Okay. I'm going to go back. Okay, so there's a host of factors, things like almost always having a mental health condition, usually more than one, even if it's not diagnosed. Again, remember, most people who have mental health conditions are not at risk for suicide. Chronic health condition, chronic pain, a history of abuse and neglect or violence, a family history. Head trauma is a factor that often contributes to suicide. Previous suicide attempts, chronic high stress victimization, genetics, all these things are going on in the background. And what you see are the life events and stressors that happen. So often people make the erroneous conclusion that it's the stressor that caused the suicide. But it's the combination of underlying vulnerabilities that are heightened. So let's say you're in a full episode of your mental health condition, or you're having a pain flare up, and then stressors. And then in order for somebody to actually die by suicide, they clearly have to have lethal means. So all three of these conditions are in play when somebody dies by suicide. There are also, I'm going to move on to show you some of the contributors. As I mentioned, previous suicidal behavior, mental health condition, all these things I've mentioned already. In addition, there are protective factors, and those protective factors include resilience, social and problem-solving skills, feeling connected. And note, I'm saying feeling connected, but also people who die by suicide often have what I call disconnection. And you might hear this on your calls where they say, I know my family loves me and I love my family, i.e. they're connected to their family, but they'll be better off without me. So it's a dysfunctional connection. It's not necessarily no connection. Also, social support can serve to help mitigate risk. And two very important factors that we need to assess are the willingness to participate in mental health care or treatment and access to mental health care. So those factors can help mitigate a person's risk in the moment of stress. However, often when somebody is in that crisis moment, and we know that what happens with suicide is these contributors are kind of tootling along, they get worse, they get better, there's a stress, they get through it, but sometimes they align in a way that a person doesn't have access to their usual coping. And in fact, these protective factors fall by the wayside. They can't access their problem solving. They think nothing's going to help. And they end up with what we call kind of, in a crisis moment, a tunnel vision. Now, I selected this picture because you'll notice this is a telescoping tunnel, which means that if a person's feeling this way, we can help them expand their thinking to increase their flexibility. And there will be blue sky with some clouds in it at the end so that they can get back to coping, problem solving, connecting, and accessing their protective factors. But in that crisis moment, which we know is often very short-lived, they believe that the family will be better off without them. The pain is never going to stop. They don't belong. They only see like tomorrow's going to be terrible. They can't look towards the future. They don't see options and they can't access. They feel desperate and like there's no escape. So our role as clinicians, and especially in EAPs, you probably confront this a lot. You have somebody in this state, that state could change pretty quickly just with some active listening and with non-judgmental support. So I'm going to talk more about that in a little bit. But in the meantime, I want to move on to the warning signs. Like, how do you know that somebody might be at risk. Now, if you're an EAP and you're on the phone, some of these warning signs you're not going to see, but you can ask about them. I'm going to share this video because it says it all. These are real people who had real suicide episodes, and they have gotten through them. They've had more, but they're doing well at this point. I hope you can hear it.
Oh, nope, we don't.
Can you hear it?
No.
Oh, because it's not in presenter mode. Let me see if I can get this in presenter mode. Let me try it now. Yes or no?
No.
Okay. Basically, then I'm going to move on to the slide that talks about what they're talking about. It's unfortunate that the video, I should have tested that before, that it's not working. But those are just people talking about these experiences that they had. And the way we think about warning signs is there are things that people say, do, and feel. Now, these warning signs, they don't happen 5 minutes before somebody's going to make an attempt, or a day or a week. Sometimes they come and go. Sometimes people hide them. So I don't want to make it sound like you should be able to look for these things and you'll definitely know that somebody's at risk or not. But if you see them, you want to start to have a conversation with them. So what do they say? They talk about killing themselves. And they might even say it very casually. I wish I would just die, and they make a joke, or about actually taking their lives. They say they have no reason to live, or that, like I said, they're a burden, but they feel like they're trapped, they're in horrible pain, and nothing is ever going to get better. And sometimes they don't say it that boldly, but they say subtle things like, well, next year I won't really have to worry about this. There's also the things they do. So increases in alcohol or drug use, looking for ways to kill themselves online or in their environment, acting recklessly, because what does reckless mean? It means that you don't really care what happens to you. Pulling back from activities, isolating from people, changes in sleep, most importantly, insomnia is a strong warning sign for suicide. Saying goodbye to people. One of the men in the video says, I told my parents they did a good job. I gave my favorite guitar to my friend. Those kinds of signs. And we have a great PSA called Talk Away the Dark, which I recommend that you look at. It's online, Talk Away the Dark. It's on our website, afsp.org. But it talks about these warning signs and then how a family member can have conversations with them. You might also see aggressive behavior or agitation. In terms of mood, we always think that people are depressed, but they don't always have major depression, and they're not always depressed. They may lack interest. They're apathetic. They may feel rage, intense rage, irritability. Humiliation is often a key feeling. That feeling of humiliation can be in the moment of how a stressor could in the moment lead to suicidal behavior. They may feel anxious and they may feel hopeless. And I'm sure that as you talk with people on the phone and you've had people who may be thinking about suicide, you've probably seen and heard these things. So what do you do to assess for suicidal behavior? Well, first, ask. When I started in the olden days, you were not supposed to use the word suicide, and you're not supposed to say it, because if you ask someone, that would put the thought in their head. Now, I've just showed you that suicide is much more complex. You can't just put the thought in someone's head. And I'm happy to say that these days, if you don't ask as a clinician, that's the time that you're going to be liable. If you ask and you listen and you have a full assessment and you document what you did and why you did it, you're not expected to prevent every single person from dying by suicide, but you're expected to assess for it, have a plan, discuss that with the person and their supports, and get consultation if you need it, and document all that. So when you ask, you will not make somebody suicidal, but you might miss an opportunity to save their life by not asking. And we know that people feel relief when you ask. Even if you ask them and they say, no, I wouldn't do that, but they're really thinking about it, it relieves some of the pressure of a suicidal crisis. So it's so important that you listen without judgment. We start with not saying, you're not thinking of killing yourself, are you? That's a very judgmental statement. And it also says that if you are, I don't want to hear about it. I agree that when you ask people and they say yes, it can be a frightening moment. But if you're equipped with what to do, then you'll be able to manage it and deal with it. So you just start by telling the person what they've told you in your session with them, asking them what worries you. You mentioned you're not sleeping. You mentioned you having trouble getting to work. Sometimes when people feel that way, they think about taking their life. Are you thinking of taking your life? Do you have a method in mind? It turns out that if people mentalize either, which means basically having mental imagery of either being dead or killing themselves, that is a strong predictor and risk factor to ask about and keep in mind. We don't want to start trying to argue people out of it, because arguing them out of it just makes them dig their heels in deeper to why they should try to kill themselves. So we just let them know that we understand, we hear them, that they're feeling desperate, and that this is a health condition that we can help you with. You want to ask because you want to know, and because people will share, they will tell you. The times that people won't tell you is when A, they're not feeling it in that moment, B, they're afraid you're going to hospitalize them against their will, or C, you're their therapist and they don't want to disappoint you because they're still feeling suicidal and they don't want to hurt your feelings. So you want to ask because people will tell you. And you also may want to make it clear that what will happen if somebody tells you. So just because somebody's thinking about suicide doesn't even mean they're at risk for suicide. In 2023, about 16 million people thought about suicide, about 1.3 million made an attempt, and 49,000 plus died by suicide. So many, many people think about it. Even people who make attempts, only about 10% of them, sadly, will go on to die by suicide. So it's about having a deeper conversation. So you start with, have you ever wished you were dead or thought life would be easier if you were gone? Have you ever thought of taking your life or killing yourself? I personally don't say, have you thought of suicide? Because people have all different kinds of ideas about what that means. And then I want to know, how often have you been thinking that? How long do those thoughts last? And what kind of thoughts have you had? And that's where you can get into, do you have a plan? Do you imagine yourself dead? Can you visualize it? Have you ever actually made a suicide attempt, and how many times? And then if they have, what did they do? What led up to the attempt? Did they need medical attention? And what did they feel like right before? And that's a very important piece of information, because that's information you'll use in a safety plan, which I'm not really going to go into today, but I'll mention it. So then with assessment, I'm not sure if you're using specific assessment tools or not, but here are some tools that are used to ask about the presence of suicidal ideation and history of attempts. And it's not in and of itself just a risk assessment, because a full risk assessment involves asking about all those other things that I mentioned. And guess what? If you do a full evaluation, you're going to ask about those things anyway. But these assessment tools are really helpful because they provide a structure for asking people and then recording their responses. They're very easy to learn. Now, obviously, the questionnaire, the suicide behavior questionnaire, you give to the person, but you can ask these questions as if they're conversational and write down the answers. You don't have to sit there. For instance, here's the ask. You don't have to read, in the past few weeks, have you wished you were dead? But if you practice it enough, it's pretty straightforward to say, in the past few weeks, have you wished you were dead? And then the ask is 5 questions, and it has pretty good sensitivity to people who are at risk. There is a bit of a false positive rate. In other words, saying somebody's at risk when they might not be, but it's just offering you an opportunity to dig deeper. So you're going to ask, and it's very similar to the CSSRS, and the behavior questionnaire is a little more in depth. But you're going to ask, did you feel you would be better off dead in the past week? So you're narrowing the scope. Have you had these thoughts? And have you ever tried to kill yourself? And you want to ask how and how many times. And if you get a yes to any of the above questions, you want to ask, are you having thoughts of killing yourself right now? Now, again, it's really important for people to know that your answering honestly is so important, because that's how I can help you. If you say yes to this, we're just going to have a deeper conversation and come up with a plan together. So it's really important that you share what you're feeling and let them know you're not going to call 911 and have them scooped up. There are also standardized measures of suicide risk that ask these deeper questions about history. And again, I'm going to give you a PDF of this, so don't worry about writing all this down. But there is the SIBAT, the MINI, the CSSRS, the LSSN, and the SCS checklist. Now, these are all acronyms. They all actually stand for something. I want to point out the SCS, which is the Suicide Crisis Syndrome checklist, because that assumes that a person can still be at risk even if they said no to the question, are you thinking about suicide? And it gets at those feelings of entrapment, hopelessness, things are never going to get better, which are key features of when somebody takes their life. So let's start. So what I want you to take away from this, and so far nobody has any questions. Can we stop for a minute and see if anybody wants to ask any questions? I can't see the chat.
I do not have any questions in chat yet.
Okay. I'm wondering, I hope this is relevant to your experiences and what you've had in your conversations and work with your clients. So what to keep in mind is that, and when you're on a brief call, you can still ask about all these questions. It helps to have a little checklist like one of the risk scales, but keep in mind, if you're, let's say you're in clinical practice and you're sitting with the patient, keep in mind, what are the patient's contributors or risk factors to suicide? And keep an eye out for warning signs. Have a conversation with them if they've ever thought about it, about how would I know if you were thinking about suicide? Would you let me know if you're thinking about suicide? I know that your mother died by suicide. Do you think that that will happen to you? So really keep in mind the person on the phone or in your office. And you can get those histories very fast. We do it in emergency departments all the time. Use screeners about current and past suicidal behavior, and assess the contributing factors, protective factors, supports
Jill?
that are available. Yeah,
We do have a question.
great.
Jeanette would like to know, what assessment do you recommend for the EAP setting?
So for the EAP setting, and is that mostly on the phone or it's
Jeanette,
not in person, right?
do you want to unmute and talk to Jill?
It's okay if you don't. So in an EAP setting, I think that I never fully recommend any particular instrument unless I know what the person's doing, but the ask is really helpful for getting those first questions in about if this has ever been on the person's experience and if it's happening now. Each of these instruments, the ask and the CSSRS, are actually asking basically the same questions, and it's more how you ask it. So I think that, first of all, the ask is available at the National Institute for Mental Health website. It's free. There's a guidance for how to decide if somebody has risk or not. So I think it's often a safe bet to use that. Many people use the CSSRS. It asks some of the same questions. It gets into details that it's not totally clear are informative or not, but either of these questionnaires, there's no downside to using them. But whatever you ask, you want to ask follow-up questions, because these are just this really, are you thinking about suicide now, and have you ever made an attempt or thought about it? You want to get a sense of what their plans are. You can also do it in combination. So I think using either the ask is very quick. So using the ask and the SCS, the suicide crisis syndrome, and there is a book about that, the suicide crisis syndrome, that combination can be very, very helpful, because it's going to ask you, not necessarily, you will know about whether or not they're thinking about it, but the SCS will also ask about whether or not they're feeling desperate, whether they feel things are ever going to change. And that's an important part about the suicidal state. So I think I would use those two questionnaires in combination.
We have another question.
Great.
How do you suggest in addressing a savvy teen who may not want to disclose suicidal ideation to their therapist because they know they may be hospitalized and don't want to be, but the parent has disclosed that there's been talk about it?
Right. So I think, well, go with the resistance. So if you have a teen, so I did a lot of work with teens, and I think you kind of just have to be honest with them and say, listen, you may not want to tell me because you think I'm going to rush and hospitalize you. So let me assure you, that we're going to have a conversation, and we're going to start by coming up with a plan together. So the more open you can be, the more I can help you. And I'm wondering, I see that X, Y, and Z is happening. And I know that sometimes you think about suicide when that happens, or you've even made attempts. So let's talk about it and figure out a plan. And then I hopefully would already have a safety plan with the person, but if I didn't, I would develop a safety plan with them. Let's talk about what you can do to not act on those thoughts. And of course, you want to know how much they feel. So you want to reassure them that the first step is not going to be hospitalizing them, but rather coming up with a plan. But if you're talking to them and their plan is completely unrealistic, or they're unwilling to do that, then I would be concerned that there's something I should truly be worrying about. And I would say that out loud to them. If we can't even talk about it, then I'm going to remember I talked about limits of confidentiality in the beginning. I would be a terrible therapist if I didn't do everything in my power to keep you alive so that you can get on the path to feeling better. So let's talk about it. You may decide that a hospital or a crisis center might be helpful, but that could be a choice we make together. And I would put, the agency is in their hand anyway. They're either going to tell you or they're not. And in the end, as much as we want to keep people alive so their lives could get better, sometimes that doesn't work and they take their lives. But I think that's part of the idea of understanding that ultimately they have the control, but we can enlist them in engaging in life-sustaining actions. And the more straightforward you could be, and also talk to them about, what do their parents know? You might even disclose that the parents know and they're concerned, and try to just have that conversation. And sometimes I think I once had a conversation with a teen wearing sunglasses because they didn't want me to see their eyes and what they were, what get an inkling of what was going on. So I just put on my sunglasses, and that actually just freed up the whole session to have like a real conversation. So I think you have to be creative, but also you're the clinician, you're not their friend. And your most concern is that they get through this difficult time and that you believe that they will and can feel better. It was kind of a long answer to a short question, but
That was amazing. We do have one more question,
sure.
which is, where do we access the suicide crisis syndrome assessment?
You can get it online. And also there's an excellent book called The Suicide Crisis Syndrome that it's pretty for clinicians. It's easy to read. It also I think the tool is in there. And if not, the author is Dr. Igor Galenker, and you can always write to me and I can send you the reference and contact. So, and I'm available at jharkavy-friedman @afsp.org. We're very creative with our emails. So it's a very short questionnaire. And if you can't get access to it online, I can, or contact Dr. Galenker. It's being used now in many, many hospitals and clinics. Any other questions or welcome questions?
That appears to be it for the moment.
Okay, so I'm gonna, as I read this last line, I want to talk a little bit about access to lethal means. And also, I will say a word about safety planning. I don't know, a lot of places now they're already trained in safety planning. And safety planning is a plan for safety. I'm going to go over just briefly now, just in case you haven't heard of it. There is an app, the best app right now that's I think is good, maybe only for Apple though, is the VA actually developed an app. I think it's just called the Safety Plan, but you can go to your on your phone or whatever to that section and put in safety plan. But a safety plan, if you use one, has to have these components at least. It starts with, and it's collaborative, it's their plan, it's not your plan. It's not like, this is what I wish you would do if you're feeling suicidal. This is what you feel you could do if you're feeling suicidal. So that would include, first, how do you know when you're heading towards a crisis? And it is that crisis moment, even for people who think about it for years, the moment at which they act on it is often a crisis moment. And we know that it has a crescendo and then a turning point, and then it will de-escalate if they have time and hopefully some intervention or plan. So a safety plan is that plan. It has multiple steps. It's written down or put in an app. And it's best if it's done with the clinician because not everybody is able to generate the answers on their own. So the first thing is, how do you know when you're going down that road? How do you know when you're, you might start thinking about suicide, or maybe you've even had a couple of thoughts. So often things are like, I start pulling back, I'm getting in fights, I feel like nobody understands me, I have trouble sleeping or eating, I start drinking more. So what are the things that they see? And if they can't think of anything, you can throw out those ideas and see if anything sticks. And then the first action is, what can you do just on your own to de-escalate a crisis moment? So what can you do to distract yourself and help yourself to feel better? And so I think I'm going to take off the sharing since I'm not talking about this, and I'll try to get it back. Wish me luck afterwards. So distraction is okay if it helps avoid a crisis. It's not a dirty word. So maybe it's exercise, maybe it's watching a happy movie, maybe it's watching a sad movie, maybe it's we don't want substances because that's only going to make you feel worse and less inhibited, more likely to act. So you can say that out loud even. one thing that that I always think is important to include in a safety plan is breathing. It's portable. We can all do it. And we can all find some kind of breathing exercise that helps us. But even just inhale for 3, hold for 3, 4, sorry. Inhale for 4, hold for 4, and exhale for 4. And doing that 3 times just turns down the volume on a crisis. You can do it while you're sitting in class. You can do it while you're sitting with patients. You can do it anywhere, and you can do it multiple times. Not everybody likes breathing. Some people like to imagine something. I have no visual memory, so imagining a scene does nothing for me. But I do breathe. And so having something that's very portable and quick, but other things that they can distract themselves with. Yeah.
We do have a hand up. Somebody else has a question.
Oh, yes.
Michelle, would you like to unmute?
Sure. Thank you, Julie. So, okay. Hi, Jill. How are you?
Hi. Hi, Michelle.
Um, okay. So, not to put you on the spot, and I'm not, it's not my
That's
intention,
okay.
but
That's okay.
I am coming with a bit of a challenging question. Um, so the question, I think, and I'm sure everybody can relate, it's not that there's not ways to deal with these crisis situations, an escalation of our catastrophic feelings, etc.
Mm-hmm.
But but what I have found at times is a resistance to set practices.
Yeah.
So, right, so it's like, how do you get somebody to a space? And again, I'm not even saying there's an answer or, a direct line, but it's like, oh my gosh, this person is just absolutely in a fixed state and essentially unwilling to even consider, that there could be other possibilities.
Right. Well, but they've called you, right?
Okay, yes.
So, and suicide is, there's always ambivalence. And I just also want to say, sometimes if somebody's unwilling, but you have very strong reasons to believe they're at risk, then you have to take action without them. But that is not ideal, and we want to avoid that. But I think that you're right. People call, and also doing a safety plan, which I will get back to.
Mhm,
I don't have anybody. There's nothing I can do.
mhm,
You can start with, well, I'm really glad you called. What was on your mind when you called? What were you hoping to find when you contacted me? What kind of distress were you in?
mhm,
And so some of the research we funded that looks at literally sessions on like the crisis text line, they find that first it's just that, I know we learned this, but that empathy and being heard, and
mhm,
then that de-escalates that emotion dysregulation and
mhm,
that fixed thinking. So
mhm,
even if you're just talking about it, so what led you to do this? And that these crisis sessions actually are a series of you know listening, emotional listening, and
mhm,
then the person might open up to some problem solving. So you go that route, and then they might close up again, and then you just go back to that emotional listening. But it's gradually, hopefully, you can get them to open up. If they absolutely won't, which often just being heard at least de-escalates the stress of that crisis moment. Again, addressing, well, I'm really glad you called. And a lot of times people have mixed feelings. Might you have mixed feelings? Might you feel like things are never going to change, but maybe you have a little bit of an idea that it can. And if you don't write this second, here are some other things you can do. You can call 988 in a moment. We can develop a safety plan right now to help you through these. This is a painful moment. I understand that. And I think we both want that to pass so that you can start making your life better. So having that empathic listening, But in the end of a call, you want to make sure either conjointly or just you giving it to them, they have some steps that they can take to feel better so they don't have to end up with the police showing up at their door to hospitalize them. You don't want that, and they don't want that. And conveying that can be really helpful. But don't bring up the police until, don't say the word police. You can say somebody showing up, You can also, is there somebody with you that I could talk with, that could be by your side right now while you're feeling this way? In my study, we had 2 years of follow-ups, and what happened one time, my research assistant called someone and they said, well, actually, I'm thinking about it right now. What are you going to do? Well, I was thinking I would drive my car into a wall. Okay, so do you have your car keys? Yes. Who's in the house? My mother. Do you think you could go give the car keys to your mother? Yeah, I could do that. Okay, do that and come back. So it's about meeting the person where they are with an open mind, reassuring them that your goal is just to help them through this moment. And a phone call, you're not going to change somebody's life, and you do your best. And if they really won't tell you, if you were worried about a friend, I would say to you, ask them again in a little while. Accept that they're fine, and then come back to them again. So like my 4 words, these are my 4 life words. You probably have, I don't know why 4, but that's what I got, are compassion, respect, patience, and persistence. And I found if I keep my focus on those 4 things, and compassion is more than just, oh, I feel so sorry for you. It's and I think you can feel better. And respect, people respond to respect because they feel so low that they can't even believe anybody would respect them. And then patience and persistence, because they may or they may not. If I have a family member who's worried about somebody and the person won't talk about it, I'm a big fan of leaving literature on the table. Leave a brochure, leave a 988 card, leave a therapy center card or something. So just exposing them to what's possible. That's the patience and persistence, and take a breath yourself.
Yep. Thanks so much.
Because it definitely happens. You're not putting me on the spot. I've been in that situation. I did not know with that teenager that I was going to take out my sunglasses and put them on, but it worked. So you have that, you have some trick. You do the best you can, and most often it actually helps. So to get back to the safety plan, but I welcome other questions. So first is how do you know you're headed down that path? The second is, what can you do to feel better? And a lot of times when people are in a crisis, which is why you want a safety plan, because that's not a good time to figure out what you can do in a crisis, but sometimes that's where you are. You can always offer breathing. Then who can you be with to distract yourself? You don't have to say anything, but you could just be with people just to distract yourself. A lot of times people say, I have no one. But it turns out they do. So you can kind of dig deep. Do you have friends? Do you have relatives? Do you have a place you frequent a lot where you like to talk to the person behind the counter? Well, you could go there and chat with them. That person doesn't have to know what you're thinking and feeling, but they can just help to distract you from the intense feelings that you're having right now. Then it's who can you call you can say, I'm feeling suicidal, or I'm feeling crummy. Can I talk to you about it? And usually there's 1 to 3 people on that list. Obviously, the more the better, because people, and you have to talk about it, they may not be available in that moment. So use the other techniques to hold on to get to that moment. And literally, there used to be a great app, but it doesn't exist anymore, called My3, where you could have 3 buttons and you could program 3 people. And all you have to do is push the button. So make sure you have the phone number of the person, or that they don't have to start looking it up, because honestly, who knows anybody's phone number anymore? I barely know my own. So who can they call to really, or go to? to talk about how they're feeling. The next is, and this is where we come in as professionals, right? Because if you're seeing someone, for instance, in therapy, the goal is not for you to follow them around their entire life and tell them what to do. The goal is to help them develop the skills and emotional capacity to get what they need. So this is where professional comes in, 988 comes in, maybe the Trevor line comes in, the veteran crisis line. It could be RAIN, if some, depending on the person's experience. If they have trauma, there are trauma lines, but put those down. And then the last two things are limiting access to lethal means. And, there's some debate, should you eliminate all lethal means or just the ones they were thinking of? I'm a fan of eliminating them all if you can. But if there's something that's in their plan, the idea is if you don't have something to kill yourself, even if you act on it, you'll survive. But most people, they're in that fixed state. You take it away and they can't think of something else, because that's kind of the positive of tunnel vision, is that they're not quick thinking. And really what are you thinking of doing? Well, I'm thinking of taking pills. Do you have pills? Yes. What do you have? Okay. Can you go to your medicine chest, get those pills and give them to somebody, or flush them down the toilet? Turns out they do want you to flush opioids down the toilet. I'm not sure why. But if they don't know how to get rid of them themselves, take the pill container, put a little coffee grinds or dirt or something inedible and a little water, close it up. You've now gotten rid of those pills. If it's a firearm, where can you lock it up? Who can you give it to? There's an excellent app called Lock to Live, where it's a decision-making tool for the person to decide based on their circumstances what they can and should do. And there are also safe storage maps. You can Google gun storage near me, and literally a map will come up that shows you where you can store your guns. So there's always a way. There's a story I told about the person with the keys, but limiting access to lethal means, even if they're not planning to use them, because the crisis moment, if it comes, you want them to not have it available. And then finally, what's keeping you going? What is something you're looking forward to? What are your reasons for living? It turns out reasons for living are the strongest way to keep people alive. But when they're in that moment, they're not necessarily thinking of it. And I worked with a 20-year-old who, he had a terrible family. He had made a terrible suicide attempt. He was out of school because of the suicide attempt. I mean, he really had very limited resources. He was very bright. Actually didn't know why he had made the attempt. It turned out he had no cortisol. He probably had Addison's disease. And as soon as he got cortisol, he went back to his normal self. But he couldn't come up with anything. And I was kind of like, nothing that you're looking forward to, even in the next weeks or months. And they came up with a video game he was waiting to come out. And I was like, okay, I'll take it. And we'll revisit this in a month when it comes out. And that's the other point. A safety plan is a living document. And as you hear things changing, and then along the way, you always want to ask, would you do this? Is this something you would do? So that's a safety plan. And I highly recommend that. One thing to realize is that when people haven't thought about it that much, a safety plan doesn't actually make sense to them. It's really meant for people who have either made an attempt in the past or have, significant suicidal thoughts, and you can kind of work it through to help them learn to de-escalate that. But if they haven't gone that far, they're going to look at you like, what are you talking about? So I want to go back to my slides for a second. Can you see that yet? No.
Not yet.
Okay. It wasn't on my, because I got a reminder. Okay, let's see. Here we go. Of course, I have a reminder telling me that I have a meeting in 15 minutes and it's blocking my screen. So, of course, we love technology. Okay, now, let me come back to this. Here you are. Okay, let me see. I'm going to try one more time. I don't
Okay.
want to spend too much time on my screen. Windows. No, it's not coming. Okay. I'm going to stop with the slides. And, but basically I want to just review what we've been talking about. That suicide is complex. There's never one cause. And that's an important thing to think about, because if someone calls you and is saying, you know, my wife just left me and I'm going to kill myself, that also doesn't mean they're at risk or not. You need to know a lot more about them so you can, you know, have an empathic response. Wow, that's a big thing. You know, take a breath, let's talk a little bit and see what we can do to help you through this really tough situation. And then you need to learn more about them. Do they have kids? Do they have any family members who've taken their life? Do they, you know, how have they been coping with it? Oh, do you drink? Do you use drugs? Okay, that we'll have to keep that in mind. And you kind of expand the conversation with active listening. And as you expand that conversation, you are actually deflating the crisis and expanding their mood and capacity for problem solving. So you can do also a little distracting, but you can't assess if they're at risk or not until you say, have you thought about this a lot, or you just think about it right now? Have you ever had these thoughts before? Have you ever acted on these thoughts? Is there someone there with you, or are you alone? Who are other supports, since your wife isn't there, that you could be leaning on? Take a breath. We're going to, you know, talk about this so that you find a way. And then you have the skills, you know what to keep doing. But you can conduct that evaluation while you're talking to them. It just make it conversational. You could have your piece of paper out and checking things off. But and you do want to ask the questions as they're written, but you can do that in a conversational style. And then what I didn't get to show a slide of are the different treatments that have evidence base for helping people who are thinking about suicide or in a suicidal crisis. And what we've learned is, well, treating the mental health condition is important. It doesn't always prevent suicide. In fact, we've learned that people with major depression or multiple episodes are just as likely to make an attempt between episodes than when they're in an episode. That's kind of shocking, but true. So suicide has its own biology. It's connected to mental health. It's exacerbated by mental health conditions, but it has its own. So treatments have to address the ideation and behavior directly. And so the treatments that have evidence, and I'm guessing you've heard of, maybe even trained in many of these, include dialectical behavior therapy, cognitive behavior therapy with suicide prevention. You will get my slides, don't worry, it's on there with links. Cognitive behavior therapy, collaborative assessment and management of suicidality for helping suicidal ideation. For families, there's attachment-based family therapy. There's also a brief treatment called ASSIP, ASSIP. And we're now starting to have evidence for a couple of very brief treatments that can help people before they're discharged from the hospital, which I think is going to be a game changer, because the period after hospitalization is the period of high risk. One of the reasons being because they don't continue with treatment. So having something in the hospital that helps them deal with their suicidal thoughts and behavior can be a game changer. So those treatments and some book recommendations are going to be on the slides. And there's so much we can do now that we didn't have 15 or 20 years ago. So keep getting training, and thank you so much for having me. And I don't know if there are any other questions before we end.
Let's see. I don't see any questions. I see lots of thank yous and talking about what a wonderful presentation it was and
Oh,
how
great.
informative. So
Even with the slide snafu, which I've never had that, but you know, there's always the first time.
there is, and WebEx has its times where it just doesn't want to cooperate. So
I understand. I do
gotta-
understand.
have to
Just
kinda
like
roll with
people.
it. Exactly. Exactly. So thank you so much for joining us today. This has been so informative. And for those of you who want to learn more, we will be having another session on May 27th. That's for 90 minutes. That will be a deeper dive. So if you're interested in that, we will, I don't know if registration's open yet, but we will do an e-blast when it is. So keep your eyes open for that and come join us for another hour of informative times.
Well, thank you so
did
much.
not
And
come
thank
from
you
me.
again for all the work you do. And you're changing lives. And it's not easy.
Thank you so much. We will be back next week for our last session in the Spring Free Friday webinar series on silent grief. So come join us if you haven't registered already. And then we have 2 courses coming up next week that are really great, but registration is going to be closing soon, which is Jeff Gorder is going to be talking about the changing face of crisis. And that's going to be on Tuesday. And then on Thursday, Harry Levant, who some of you might have seen be our keynote in Indianapolis, who is a nationwide expert on gambling, is going to be talking about gambling and online gambling and mental health. So
I just want to tell you, I'm doing a congressional briefing with the National Council on Pathological Gambling next week. So
really,
that's very timely. Sorry, I didn't mean to interrupt, but it's a
I'm
topic that's
glad
really
you
important.
jumped in to add that. So thank you all so very much. And thank you again, Jill, for coming and joining us. I look forward to your presentation in May and learning more. And we will see you
Thank
all
you.
next week. Thanks,
Bye.
everybody. Bye.